this computer. Hi, it's December 15th, 2020, and I am with Dr. James Shepherd. And this is the second little webinar that we have done so that we can hear from Dr. James about COVID and today specifically about vaccines. And I'm going to turn it over right now immediately to James, who's going to give us a little bit of history about himself and talk about where he thinks we're going. And I just want to say that we also have with us James McDowell Shepherd, son of Dr. James, who's going to be asking some questions also. So, Dr. James, take it away.
Thank you, Alexandra. So, episode 2. As a brief introduction, I think you kindly gave an introduction last time, so I'll make this one very brief. I'm an infectious disease physician and a public health expert, a former research immunologist, and I practice at Yale. I'm a faculty physician at Yale University and Yale School of Medicine, and have been seeing patients throughout the pandemic since March at Yale New Haven Hospital, where I practice medicine. I'm also a ex-CDC and World Health Organization from sub-Saharan Africa and India. So I've had some global experience in rolling out public health programs. So we can talk a bit about that when we get to the implementation of vaccine programs. So we decided to give you a little update. Last time, I think we were before Thanksgiving and talking about where the global pandemic had got to. So in the last month or so, I think all of you will be aware that things have not gone well. And we have moved into the season for COVID. This is a seasonal virus, just like other coronaviruses. It's just that what we hoped would happen, that the virus would diminish with time, really has been quite the opposite. And we've moved into upper respiratory tract viral infection season. And here we are with exponential rise in coronavirus cases, virtually unhindered community transmission of the coronavirus in many parts of the world, certainly in the United States and Central and South America, other parts of the Northern Hemisphere, which are entering the late fall and winter viral transmission season. And so the spread and the subsequent pressure on acute medical care facilities has been intense and is increasing. We are really at the beginning of the exponential rise in cases, and there isn't a clear end in sight, particularly given the extreme reluctance of the authorities to lock down again, as they did in March and April, and basically push everybody into their respective homes and instruct them not to come out until it was safe to do so. The general fatigue, the general suspicion of the authorities, the general lack of economic support to enable people to isolate particularly those that can't work from home, has really blunted the public health response, along with some politicization and suspicion. And so we are really in a bad spot. And we expect to see the case count rise even further from here. A number of states still have not fully closed up indoor dining options, and other businesses that by their nature involve congregation. And so the fuel of viral transmission is still there. And we're certainly seeing the same at Yale, where we're about halfway in terms of COVID inpatients to the point, to the peak that we were at in mid-April this year. So we're at about 250 inpatients at Yale New Haven Hospital. The peak was about 500. The difference being that the hospital's full this time with all sorts of other patients, because we reopened business as usual, elective surgeries, admissions for all other illnesses. And so the COVID surge is arriving on top of that. So things are really in the worst phase of the pandemic, and the next 3 months are going to be the worst of this arrival of COVID and the global pandemic. Certainly worse than any other time since the virus first made the jump, the spillover, almost exactly a year ago in central China, and almost certainly worse than anything that we're going to see in the future. So the future will bring naturally a decline in viral transmission as we move out of the winter season into the spring, as we saw this year. We just didn't realize quite how lucky we were getting. And with the arrival of the vaccines that are the topic of the last few weeks. And we've been extremely surprised and pleased with the efficacy of the vaccines. They are far, far better than any of us could have possibly predicted that they would be. And I think we may have been talking last time just before the first results were reported, and I was estimating that 75% efficacy would be a home run. And the first 2 vaccines in the United States that are being reviewed, and one already approved for emergency use by the FDA, have reached above 90% efficacy, which is spectacular and most surprising, to be quite honest, with some more vaccines in the pipeline. The vaccines in the United States, and I'm talking about the Pfizer vaccine, which was approved late last week by the FDA for emergency use and is already being distributed and injected into healthcare workers, is an mRNA vaccine, which is a brand new technology. And almost certainly the second mRNA vaccine will be approved by the FDA this week, later this week, from Moderna NIH. So the first 2 in the United States to be approved will be mRNA vaccines. This is a brand new vaccine technology. The mRNA technology has been around for a decade or more as a way to introduce proteins into cells, but this is the first time it's been used for a vaccine. And obviously, surprisingly, good. It is a piece of mRNA, ribonucleic acid, similar to the mRNA in all of our cells naturally, that take the messages from the nuclear DNA and translate them into proteins inside our cells. And this little piece of mRNA codes the spike protein on the surface of the coronavirus. And injecting the mRNA in a little fatty envelope, a lipid nanoparticle, enables it to survive the injection and penetrate the cells in the vicinity. And the mRNA is then translated inside the cells. The spike protein is made from that message in the mRNA and then displayed on the cells that have been inoculated. And the immune system then recognizes it as a foreign molecule and sets to work developing a response against the spike protein. As I said, Pfizer and Moderna both use the same technology. The 90% efficacy is really the high watermark of efficacy. And by that, I mean that the trial environment, the large scale trials that were done, are usually the best delivery of any new medicine or vaccination. They're done under very controlled environment with people that are highly motivated to cooperate, that follow up. And as you know, the vaccines require 2 shots, these mRNA vaccines. Pfizer, 2 shots 3 weeks apart, the Moderna, 2 shots 4 weeks apart. Everyone shows up for their second dose. They get reimbursed for their travel, and they're keen to help out and be good citizens. And so the shots are delivered on time. And we observed from the data that some protection was already conferred just with the first shot. But the full protection to above 90% was conferred with the full 2-dose schedule. And the vaccines protected against symptomatic COVID. So in the placebo arm, people got sick with COVID. It was mostly mild to moderate illness, but there were a significant number of severe cases as well. In the Moderna trial, there were 30 severe cases in the placebo arm. But in the Moderna trial, there were no severe cases in the vaccine arm, and only a very small number of mild to moderate cases. So the 90% is the real deal. It tells us that if you get the shot, you are very unlikely to get significantly ill with COVID. And that's really the whole point of the vaccination scheme. The other point of vaccination is to prevent transmission. And that result is still unclear. So we do have some data from another trial, the AstraZeneca Oxford vaccine, which you've heard about, that suffered from some mistakes during their clinical trial development, where they gave half doses at the beginning in the UK, and then they had some real world issues in their trials, which were conducted in the UK, South Africa, and Brazil, environments that are not quite as controlled as the US clinical trial environment, where the doses were given further apart than was initially intended. So many of the doses were more than 6 weeks apart in the AstraZeneca trial. Nevertheless, it was still highly protective, between 62 and 90% protective, and it remains unclear exactly where that number will fall. But because it was the same spike protein that was the real business end of all of these vaccines I'm going to talk about, the level of protection is likely going to be similar in the end between all of them, which is very good news. In the AstraZeneca Oxford trial, however, people could still be infected. So although they were protected against even moderate illness, and certainly highly protected against severe COVID illness, there were still significant numbers of infections in the vaccine arm, which were asymptomatic. And there were asymptomatic infections in the Pfizer and Moderna arms of the vaccine arms as well. So the transmission blocking capabilities of the vaccines almost certainly will be less than the disease protecting qualities of the vaccines. But it remains to be seen exactly how well they protect against asymptomatic infection. And it remains to be seen whether if you get vaccinated but still get infected with an asymptomatic infection, perhaps the viral replication in you is significantly lower than if it was a natural infection. And that would confer significant public health benefits because you would be less infectious. Some of the other vaccines are based on different platforms. So the two American vaccines, Pfizer and Moderna, are two of the most challenging to implement because of the extreme cold chain requirements and instability of mRNA and the little fatty envelope that they use. And so you've seen all the dry ice boxes heading out of the factories over the weekend. That presents enormous challenges, and we'll talk about that in a second. What is likely to be far more useful for the rest of the world, and in fact, what is likely to be the vaccine that most of us get, and certainly what is likely to be the vaccine that people that aren't healthcare workers or the highest risk groups, namely people over the age of 75 with comorbidities, the vaccine that you all are going to get will be likely an adenovirus-based vaccine. I talked a little bit about the AstraZeneca Oxford vaccine, which is a chimpanzee adenovirus vector. It's a common cold virus called an adenovirus. It has some of its bits taken out, so it can't cause disease itself, but it can still infect. And spliced into its nucleic acid is the gene encoding the coronavirus spike protein. So it's a hybrid virus made up of a common cold virus with a bit of the coronavirus spike protein spliced into it. Those vaccines are much more stable. They can be lyophilized, which means freeze-dried. They can be transported, they can be made rapidly. They can be transported at regular refrigeration temperatures of 2 to 8 degrees. They can be reconstituted on site and given without the same need for fridges and freezers actually at the point of care. And so these types of vaccines are much more suitable for global immunization programs. And to be quite honest, much more suitable for most US public health programs operating beyond big cities and in secondary cities and rural areas, which really don't have the capabilities for storing and distributing the mRNA vaccines. The one that's likely to be the most used one, and I'm predicting here because the trial data hasn't finished and the FDA hasn't reviewed it and it hasn't had an emergency use approval. But everything looks good for the Johnson and Johnson vaccine, which is finishing enrolling in its trial this week. It is based on a adenovirus strain 26. It's been used to make vaccines against Ebola and Zika in the past. So we've had experience. There's been well over 1,000 people, 100,000 people already immunized with this vector. So we have a lot more data and experience on any side effects that are likely to be associated with it. And possibly the most important advantage is that it's a single shot vaccine. So although it's similar technology to the Oxford AstraZeneca vaccine, which is 2 shots still, the Johnson & Johnson is a one-shot deal, hopefully. And that's the trial that's just finishing enrollment this week, is testing it as a one-shot protection against symptomatic COVID. And that trial will likely to be analyzed and submitted as a package to the FDA in the first or second week of January. So that is probably the next one that they're going to be looking at. The AstraZeneca Oxford, which has accrued the required number of patients, is not very popular apparently at the FDA at the moment because of the mistakes that they've made along the way and a certain issue with communication with the US FDA. But that vaccine may be approved in the UK and possibly in other countries. There are other vaccine candidates out there, and in fact, the most widely used vaccines already, despite what you may imagine watching CNN or Fox News and watching, all of my colleagues at Yale this morning rolling up their sleeves and all the press taking photographs around them. There have already been well over 1 million people vaccinated with a Chinese vaccine, which is a whole virus, a SARS-CoV-2 virus that's just smashed to pieces with a chemical agent and then injected as a messed up, jumbled mixture of bits and pieces of virus. And they claim, but we haven't seen too much data in the international scientific press, that it is also approaching these high levels of 90% protection. And in China, over 1 million people have been immunized with that. And they've already signed a lot of bilateral deals with countries all over the world, Philippines, Indonesia, countries in Africa will be using the Chinese vaccine. And the Chinese also have a vaccine similar to the Russian one that you've probably heard about called Sputnik V, is another adenovirus vector vaccine. It's a mixture of 2 adenovirus vectors, so it's a 2-shot deal. The Russians say that it is also around 90% efficacious, but we haven't seen the data published from their trials, and they just went straight from phase 2, which is a smaller efficacy and toxicity trial in a couple of hundred people, straight into a mass rollout. So they are immunizing already. They've signed deals with Egypt, with other countries that are using Sputnik V. And so there are many, many people that have already been immunized with the Russian vaccine. And then there's the WHO mechanism called COVAX, which is going to be the third main international mechanism through which countries will access vaccine and roll it out to their populations. That is reviewing primarily the AstraZeneca Oxford vaccine at the moment, and that may well be the main one that they use. And they're estimating a need for 3 billion doses of that vaccine. So there's a lot of vaccines out there. The mRNA vaccines will be the earliest ones in the US, but they will not be the main ones that end up immunizing most people against COVID. As a public health guy that's rolled out a few public health programs in my time, I want to point out that vaccines don't protect anybody. Vaccinations protect people. And where the rubber hits the road is where the wheels come off. And I alluded already to the fact that clinical trial data is really the pinnacle, the high watermark of efficacy. But in the real world, there are any number of reasons why medicines, vaccines, interventions never quite reach those heady heights from the early trials. And you can imagine many of them. So with these vaccines in the US that require the deep cold chain, they come in 1,000-dose boxes. And at the moment, it looks as though they're only going to be distributed to large medical centers because they're really the only places with the infrastructure to handle them and immunize them. Whereas the nursing homes that contain the highest risk people from severe outcomes from COVID have not yet started significant immunization programs because of the logistics of getting the vaccine there, opening it up, getting, say, 100, 200 people and staff at one nursing home, and then having to move on to the next one with this vaccine that's decaying all the time that you've thought it out and need to get a move on. And that's still being worked out. So the logistics are the thing to watch, and we really haven't focused on them. I was under the impression that Operation Warp Speed was intended to not only be a vaccine development program, but a vaccine logistics and implementation program. But it appears that the implementation part of it has been somewhat neglected, and the funding is not there, the states say. The reagents, needles, glass bottles, diluent to dilute out the doses from each shipped vial of vaccine, apparently in somewhat short supply. So we've got great technology, but now the proof is in the delivery of the vaccination programs. So I think I'll gone on too long. I think you've got questions that I want to answer. Sorry, Alexandra.
Not at all. No, I'm riveted. So is herd immunity something we can achieve, or do you think is that relevant in this situation?
So that's a great question, because let's take the United States again as an example. And this is different where you happen to be in the world. But in the United States, which has experienced possibly one of the most unhindered epidemics, we are likely at the point right now of estimates vary, but it's entirely possible that more than a third of the US population has already been infected. And the CDC published data to suggest that the case counts that are reported, i.e. the actual detected infections with a SARS-CoV-2 swab, are a 8 to 10-fold undercount of the true number of infections. And so if we look at today's dashboard of 16 million cases, the true number may be 150 million cases.
Of people who have been infected and may or may
Who
not
have had a natural infection.
Right.
Added to that, the rollout of an immunization program. It's very unclear at what point the number of people who have some level of background immunity to COVID will reach a threshold. And we don't even really know what that threshold is. You hear the number like 70% is a fairly oft-used number based upon modeling of the epidemic, punching in various bits of data like the R number of the virus and the attack rate, etc. These things are changing. These things depend very much upon a number of different factors. So it's not clear what that level for herd immunity is. And it's also not clear in a epidemic where increasing numbers of people are naturally infected and increasing numbers of people are artificially immunized, how that will impact the spread of the virus and how quickly it slows down. But the good news is that natural infection and vaccine-induced immunity will both be pretty effective at reducing both the severity of illness and the likelihood of onward transmission. And so the brakes are slowly being applied right now, for sure, in North America, almost certainly also in other parts of the world, Brazil, India, Russia. The question of reaching enough people with the vaccine is probably more a question for East Asia, which did a far better job of containing the virus right at the beginning. And so there's only very, very small proportion of people in China or South Korea, for instance, that have been exposed, that have natural infection. Certainly far, far, far lower proportion than the numbers we're talking about here in the US. And so they will be relying upon vaccination to generate their herd immunity. And so they're already, as I mentioned, well on the way to giving shots to large numbers of people. Back to you, Alexander.
So if I had it, which I don't think I have, and I were to be vaccinated with any of these different types of vaccines, would there be any danger in that or create any problems?
That's another great question, because one group that the trials did not enroll actively attempted to avoid enrolling were people that had already been infected with coronavirus. In fact, in the current state of the pandemic, they couldn't do it because there were so many people, presumably. And I think it was the Moderna trial, it may have been the Pfizer trial. There were over 1,000 people enrolled, spread out between the vaccine and the placebo arm, that already had antibodies to SARS-CoV-2. Or at least we think they had antibodies. They could have been cross-reactive antibodies, but So only a tiny number of people were enrolled in the trials that had already been infected. So we don't know how people that have been infected will respond to the vaccine. What is likely is that your natural infection will have induced natural immunity. And so when you come to get the shot, and they are not testing people for antibodies prior to giving the shot, so you're just going to show up and find out when you get the shot, I suspect you'll have a much more sore arm than someone that did not get infected prior to the vaccination. And your immune levels, your antibodies will be stimulated and probably highly protective much earlier on as a result of that. So the vaccination now acts like a booster shot. It acts a bit like the second shot. Now, when you get your second booster, if you've already been infected and gotten the first booster, you may feel very rotten as your immune system jumps into overdrive with yet another challenge from the coronavirus spike protein. But we don't know, and we are going to find out very soon because they've started immunizing people in hospitals where, depending upon where you are, the background infection rate was anywhere from
It's very likely, right? Yeah.
Right. Oh, it's going to it's already happened, I can promise you.
James, would you like to ask your father any questions?
Thanks, Alexander. Yeah, I've got some questions that some friends have sent in to me, sort of what some people in my age group are thinking about considering the vaccines and their rollout. So one question that came up a lot with a lot of people that I spoke to was, are there well, it's not clear right now whether there actually are, but Dad, do you think there could potentially be some long-term effects that might come from vaccines that have been pushed through so quickly and that haven't had long trials like a lot of other vaccines have had in the past?
Well, the answer is we don't know, obviously. What I would say is that the trials have been huge. And in fact, the data that is being used to approve these emergency use authorizations is in many cases more, it's been tested in more people than more traditional vaccines that take years to develop, which usually are studied in smaller trials. So it's not so much the number of people to look at side effects. It's really the time, as you mentioned, just the natural arc of scientific development takes years. And so we tend to have long periods of time to look at new technologies and get a year, 2 year, 3 year follow-up sense. We don't have that. Mainly with the mRNA technologies, so the Pfizer and the Moderna, which are truly new and have not been used on such a scale, and the data is just months old. The consensus is that they're probably safe, much more likely safe than not. But it is hard to say that for sure without the long-term experience. And so when doctors review this data, they tend to look at the risk benefit. And so if you are an older person, perhaps with comorbidities like cardiovascular disease or lung disease, the benefits of the vaccine far outweigh any long-term risks of toxicity, because your risks of severe or life-threatening COVID are very high. Whereas if you are a 15-year-old kid who has extremely low risk of severe COVID, then the risk benefit becomes a little cloudier without the long-term follow-up data. And the vaccines at the moment have only been approved. The Pfizer was approved for over 16-year-olds. And the reason it wasn't unanimous, the advisory panel that met last Thursday was 17 votes for and 4 votes against approving the vaccine as written, was because of the inclusion of 16 and 17-year-olds in the approval. For the reasons that I mentioned. They didn't have the toxicity data for those younger people. The Moderna vaccine is only been tested in over 18-year-olds. Again, it's probably safe. So we're going to find out. As I mentioned, the adenovirus vectors have been used widely already. They've been used in more people for longer. And so I think to be 100% safe in younger people, I think the adenovirus vectors are a better known entity. And as I said, they are much more likely to be the ones that most of you will get anyway, because they're the ones that will be coming up in the new year in far greater production. Back to you.
Great, thank you. Thank you, Dad. If I could just, I've got another one that kind of goes in a little bit into that. That kind of goes along with some, skepticism from people in my kind of generation and age group is people are saying that a lot of friends of mine have been thinking that it's better to wait till farther down the line in case there's different variants of COVID, in case it mutates, and that's something that the vaccine wouldn't be able to cover. And so they would have to get a new vaccine farther down the line. I mean, that's going to be true for everyone who does get the vaccine. At some point, if it does, mutate, then a new vaccine will need to come out. But do you think it's what would you say to skepticism about if we get offered the vaccine in the in 2021? Would it be better to not get it and then wait in the future in case it does mutate or there are variants?
Short answer is no. So first of all, the virus will mutate. It has been mutating. Everything mutates. We mutate. Usually mutations are silent. We've seen one that may have had an effect, but will have no impact on the vaccine efficacies. And then there's reports from this week from Southern England of a new spike protein mutation in the southeastern UK, where I come from, that appears to be spreading rapidly and becoming the predominant variant. And there is some concern that that mutation, one of those mutations in that strain that is spreading more rapidly, is in the receptor binding region of the spike protein. So it's at the point of the spike protein that actually interacts with the host cell and enables it to bind to the host cell. So that's really a point of maximal selection for the virus. This is going to happen. This is a law of nature called evolution, described by Charles Darwin well over a century ago. And the law operates on all organisms as they replicate. So it will happen with widespread use of vaccines. We may select for what's called escape mutants that are able to dodge the vaccine. And so by widespread use of vaccine, those escape mutants are selected for and become more predominant. But in general, it's a bit of an issue, but it's not a deal-breaking issue. It still, the vaccine may confer a certain level of protection. It may no longer be 90%, say it may drop to 70%. What's more likely is that with natural infection widespread and continuing, with vaccine programs rolling out and becoming more widespread, the human host for this new virus will slowly become increasingly inhospitable to the virus. And the virus will settle down to a minor role of seasonal cold causing mayhem, as opposed to COVID pandemic mayhem. And it will no longer be the pandemic virus that we see this year and next year. And it will just enter the endemic list of annual viruses that we see and test for and shrug our shoulders and largely ignore as doctors, because they don't cause significant illness anymore. So I think that the down the road issues are going to sort themselves out anyway. And I think that this concern about, well, when will we have to re-immunize people to protect them, is actually going to be moot. It's not going to be an issue, because the virus will no longer be the significant issue in a human population that largely has some background immunity to it. And that is the natural process that we are currently uncomfortably in the middle of. So I don't think it's going to be an issue. And I would say, if you're going to get protected, now is the time. This is when your risks are greatest, particularly if you're someone over the age of 65 with comorbidities of a vascular or lung or chronic illness nature, if you're obese, if you have had a solid organ transplant, or you're a sickle cell sufferer. Now is the time to get protected. Next year, 2022, it will be much less of a dangerous event, just through the natural mitigation of the pandemic. Back to you.
But can I just say, but now for most of us is probably going to be late spring, early summer at best, right? What do you think?
Yes. So the trajectory right now, again, warp speed appears to be a misnomer, because I was also under the impression that the point was making vast quantities of vaccine whilst we were testing it, so that if any particular candidate proved to be good, we could deploy it straight away. Well, apparently that is not what warp speed means, because they're having to make it. And they appear to be making less than they said they were going to be making a month ago. So at the moment, by the end of the year, I think we're looking at, between Pfizer and Moderna, a total of 20 million doses, or 40 million doses, enough to immunize 20 million people, which isn't going to cover the healthcare workforce and all the people in long-term nursing homes, which I think is 35 million people. So it is going to take a while. And as I said, Johnson & Johnson isn't even going to be discussing with the FDA at the earliest until mid to late January. And even if that vaccine is approved at that time point, and they have made tons of it in the interim, the distribution and immunization is going to take months. And so really the virus, the epidemic will be already naturally diminishing into the spring and summer season by the time vaccinations become widely available for most people. And so really what the vaccines will be doing is protecting us against going through another season like this one in 2021. And as I mentioned, with the extraordinary spread of the virus right now, it's entirely possible by April of 2021, natural infection could have grabbed 2/3 of the American population, for instance. 220 million people could already have some natural induced immunity.
How
And
would we
so,
know that?
say that again.
How would we know that? I mean, now you can have a serology test, right? But very, very few people I know have had that.
Right. You can do surveys, surveillance surveys, but you have to sample the population properly so that you get a proper random sample that then you can apply to the general population, which hasn't really been done yet. They've used various ways to try and sample, like blood donation samples, people at hemodialysis. They obviously don't represent the general population and their risk of COVID infection. So they are presumptions. Yes, that's correct. And so the vaccine is just going to go ahead and just roll out and roll out. But I think the combination of the two, natural infection and the vaccine programs, will mean by the fall of 2021, we can predict that it will not be like this. And the virus will be much less efficient. Its R number will be significantly lower. If above 1, it could be diminishing at that point. And the two sort of things that I'd like to raise is one point that James mentioned. If we're really unlucky and the coronavirus proves to be slippier than we thought and does develop a very effective escape mutation to the initial spike protein constructs, all of which are pretty much the same in all of these vaccines, then there could be a brief resurgence in the fall of 2021. And the other issue is if natural or vaccine-induced immunity is less long-lived than we hope, such that the levels of antibodies and T-cell immunoreactivity decline quite significantly over the summer months, and more people are susceptible to reinfection again next fall. But I think that that is less likely. My sense is that this virus will be well on the way to becoming an endemic, regular, much milder feature of our annual winter season. And it may not be completely there in the winter of 2021, but significantly more so in the winter of 2022, where I think we won't be so worried about getting booster shots and follow-ups, etc. I don't think that's going to be a long-term issue.
James, do you have anything more you'd like to ask?
No, most of the questions that I had were answered in the presentation at the beginning. So thank you, Dan. It was very informative.
We have just a couple more minutes. Can I ask about international travel? I mean, what do you think is going to happen? What will people be able to move freely between other countries safely?
I think it's going to be a very interesting question because, as I alluded to, different parts of the world have experienced very different epidemics. The New World, North and South America, has been hit particularly severely through a combination of factors that we don't need to dredge up again. And so I think that by next year there will be significant strides made towards herd immunity throughout the New World, either through natural infection and vaccine deployment. In contrast, for instance, East Asia, China, Taiwan, Singapore, South Korea, Australia, New Zealand have controlled, they've ring-fenced at vaccine outbreaks. And so the prevalence of infection in their communities is extremely low. By far, the majority of people have not been infected, for sure. And so their risks to opening up international travel without a very widespread vaccination program are significantly greater than our risks are to opening ourselves up. As Northern Europe, the Middle East are much more similar to us than they are to China or Australia. So it's going to depend upon where you go, and it's going to depend upon how efficient and quick these coronavirus naive countries are in rolling out their vaccines. They are the countries that have been the most efficient at controlling the coronavirus, and so are likely to be the countries most efficient at vaccinating their people. And as I said, China's already making strides to do that, but it's a lot of people. And so it's going to take a long time to protect their communities to the level of herd immunity. So yeah, it's gonna be an interesting opening up, as it were, where different places will have to think hard about their national risks to outbreaks.
What about you? When are you taking, or when will you be vaccinated?
I got an email. They vaccine arrived at Yale New Haven this morning. I got an email last Friday that I was in the first group to get immunized. They're doing it by alphabetical order, and they're randomly selecting people from each letter in rotation. And the point behind that is that particularly with the second shot, the booster, there'll be a significant amount of fever, muscle aches, fatigue associated with it that will both confuse our COVID symptom monitoring tracker to try and keep people that are infected out of the hospital. And also people will be looking to take a day off to recover from the vaccine itself. And so they're not doing it by unit, where, obviously they would have whole units out of commission. So I don't know. I guess my name will get drawn out of a hat when the S's come round, and it'll either be the Pfizer or the Moderna vaccine. And I did think Should I get it? Am I sure? I certainly sympathize with my colleagues who are a little more suspicious. One of the big challenges is going to be in communities that traditionally have not been treated well by authority and are highly suspicious of um, people coming in and giving shots. Um, and I can understand because I've gone through the same thought processes that James asked about. Is it safe? How do we know that? And in the end, we don't really 100%, but then we never do. And you just have to balance the risks and benefits. And I think on balance, the benefit for someone like me outweighs the risks.
Would there ever be any reason to take a, since they work differently, the vaccines, is there any reason to take more than one? Or is that just, I mean, you're using up vaccines that other people could use, of course, but would that work? Is that necessary?
So that's a good question too. People are already talking about the real world, as I mentioned, when the rubber hits the road, we're going to have so many people. For instance, right now, I can assure you, there are people that have been given the card that said they have the Pfizer vaccine and they've already lost it. And so when they come back, there'll be Pfizer and Moderna vaccine being immunized, probably in the same place by the same nurses. And they'll say, "Where's your card?" And they'll say, "Oh, I lost it." Well, which one did you get? I think I got the Moderna vaccine. And so there's going to be a lot of mixing and matching. There's going to be a lot of people that were primed and then show up for their booster 2 months later instead of 1 month later, or don't show up for the booster at all. It's always a common problem. And so the real picture will be a much cloudier one that doesn't have 94.5% efficacy attached to it for sure. And there will be people getting the mRNA vaccine and then an adenovirus shot for sure. These things remain to be seen. It's part of the reason why the CDC is monitoring, and they're going to try and persuade everybody that gets the shot to download an app on their smartphone to report in if they get any toxicities or symptoms, or indeed coronavirus infection. Because the only way we find out if there's any problem with mixing and matching or showing up too late for the booster or only getting the one shot and then forgetting about the second one is follow-up, is through monitoring of the long-term effects of these brand new vaccines being rolled out. And so we will find out.
Yeah, I know. I took Shingrix, which is a two-part thing, and I got the first dose, and then there was not a second dose available anywhere or that I could find, which makes me nervous for this because that is not crisis level. That's simply something that's advocated for people my age. But I know they're holding back half the doses now for the second round, right? But that's perfectly likely to happen in the future, that there'll be it'll be very hard to control this, right?
I am actually of the mind that they should just send it all out now. I think holding it back is a pipe dream because it's never going to work properly. There's always going to be mix-ups and logistic problems. And for the situation that we're in, with the extraordinary exponential spread and the death rate that we are going to observe, in my mind, getting a first shot into the maximum number of people is a far more effective public health strategy than trying to thread the eye of the needle and only give half that number the exact right first dose and then 3 weeks later the second dose. I disagree, and I think that that's a slightly obsessive compulsive approach born of lack of experience rolling out a massive public health program.
In our local paper, we are neighbors in Sharon, Connecticut. On this past week, there was an article in the top part of the paper that's talked about the terrible shortage of nurses and how that's just going to get worse. And in the bottom part of the front page, an article about a local deli owner, I think, who doesn't believe that in masks because she said, "I feel they're not necessary." And I'd love to hear your response to what you're think. I know what you think about masks, but I'd love to hear you talk about, what we should be doing right now until we get vaccines.
Well, my feelings about masks are that I hate them. I have to wear one. I just spent 2 weeks as the consultant at Yale over Thanksgiving, wearing a mask for 10 hours a day. And honestly, it gives me symptoms of COVID. My throat starts to get congested and sore. And I was seriously beginning to think that I was developing some sort of syndrome of inhaling little fibers from the mask that were then pinging off the back of my throat. But where we are right now is a very, very, very dangerous place. And I would not be surprised if come the spring relief of reduction in coronavirus transmission efficiency, we will reach 500,000 deaths. And if wearing a mask can reduce that number even by a couple, but we hope by a significant amount, thousands and thousands of people will not die if I wear my mask and you wear your mask. It's really as simple as that. Next fall, I suspect you can wear a mask if you really want to wear a mask, but we may find that the levels of transmission drop so low during the summer and fall through natural immunity, vaccine-induced immunity, and the season, that there will be far, far lower risk and the death rate will be much, much lower. But right now, for the next couple of months, it's not a great deal to ask to save thousands of lives by wearing your mask. That's all. That's it. There's no other philosophical or political statement to make behind it. That's all it is.
Thank you. I'm glad you said that. And can I just ask you what beer you're drinking? I see that you're drinking a beer there, Dr. James.
Now we've come to the commercial segment.
Exactly. The other job.
As the largest hop producer in Connecticut, I'd like to showcase another brew. I think last time it was Table Terroir, made by Two Roads Brewing. This one is Kent Falls Brewing, which is Alexandra and James and my local brewery in Kent, Connecticut.
My favorite.
This one is Bird Post, which is a pale ale made solely with hops from Smokedown Farm, where I'm sitting right now. And I can honestly say, and I know you will believe me, it's probably the best beer I've ever had in North America. It is hoppy, but not overwhelmingly so. It's complex with notes of pineapple, Chinook hops, mango, a little bit of grapefruit in the aftertaste. It really is a delight. So if you can get a hold of Bird Post by Kent Falls Brewing, it's the one to get.
So when you're not an epidemiologist practicing at Yale, you are growing hops. Would you explain?
Yes, we started Smoke Down Farm, which, as I mentioned, is the largest hop yard in Connecticut. It's one of the biggest in New England. We've spent a lot of time working out how to grow hops, very complicated crop. And this year was our best year. We're slowly getting better at it. James has been involved, as have my other sons and Shrivi. And we now produce some really excellent high quality hops that are sought after by local craft brewers in Connecticut. And there are a lot of beers in Connecticut now that you can drink with Smoke Down Farm hops. They have a real terroir, so they take on a characteristic of Sharon Mountain, which adds to their allure. So if you find them, if we do episode 3 of the pandemic, I will showcase another local brew with Smoke Down Farm hops in it.
Great. And I have one, thank you. Happens to be my favorite beer too. It's actually the only beer I drink.
Excellent.
One last question. If once you have the vaccine, how long will it be before you will be effectively immunized? Or is it a few weeks, or is it immediate? Or
so as I mentioned, the first dose confers, at least for these mRNA vaccines, which we know the most about, the first dose confers some protection. It doesn't confer 95% protection, probably significantly less than that. But the second dose confers the highest level of protection. And the 95% protection is based upon analysis, I think it was 14 days after the second dose, so 2 weeks after. But the immune system begins to make antibodies 7 to 10 days after a challenge with a virus or with a vaccine. So you are building resistance within 7 to 10 days after the first shot, but you get the full protection after the second shot.
well, hopefully when we next speak, that things will be rolling along. So it's December 15th, 2020. A really unusual year. And I've been talking to Dr. James Shepherd and his son, James Shepherd, and about the vaccine, in case you came in late. And thank you, James. This was great.
Thanks, Alexandra.
Good night.
Thanks, Jamesy.
Thanks, Dad. Thanks, Alexander. It was great. Really informative.
Good night.
Bye-bye.